Students, we were discussing that there are 6 major drug groups that are used for the treatment of hypertension. These groups, if we go into classification of antihypertensive agents, is the number one is angiotensin antagonists. All the drugs that include to block angiotensin. The first class in angiotensin blockers or angiotensin antagonists is angiotensin receptor blockers. These drugs block the receptor of angiotensin. These are also called sardines because all the drugs have a suffix sardine or ending on sardine. Losartan, valsartan, candesartan, irbesartan, telmisartan, and there are many newer agents as well. Then there are ACE inhibitors. These are called prils or the captopril, ramipril, enalapril, cosinopril, conapril, lisinopril, and fosinopril. Then there is competitive inhibitors of angiotensin 2. Angiotensin is released and it binds with the receptor. For blockade of receptor, these drugs are used, and intermediate pathway blockade is ACE inhibitor. While if angiotensin 2 is there, but you can have a drug that is sorelasin, which can block the binding of angiotensin 2 with the receptors. What are the functions of angiotensin, how it is being released, what are its physiological factors, why it is blocked in pharmacological treatment, we will see in lateral slides. Then there is direct renin inhibitors like alisecrine. These block the renin release. Then we have sympathoplegics. As we have seen in the pathophysiology, that overactivity of sympathetic nervous system may cause hypertension. So sympathoplegics are those drugs which actually decrease or block the activity of sympathetic nervous system. Thereby these drugs can be used in hypertension. So most of them are not actually being used currently except methyl-dopa and clonidine. We have further classes in sympathoplegic as centrally acting. They act through central nervous system, clonidine and methyl-dopa. Then we have adrenergic neuron blockers like rezapine, gonethidine, and dabrisucoin. Then we have ganglion blockers like pentolinium and trimetafan. Then we have adrenergic receptor blocker. These drugs block the adrenergic receptors. Adrenergic receptors are those receptors which actually mediate the function of sympathetic nervous system, like alpha receptor, beta receptors, and these receptors in normal physiology raise blood pressure. But if you block these receptors, so you can stop raising blood pressure. So we have alpha 1 blockers like prazosin, phentolamine, phenoxybenzamine. Then we have beta blockers. There are 2 types of beta receptors, beta 1 and beta 2. Beta blockers block the beta receptors, either beta 1, beta 2, or both. So beta blockers include propranolol, nadolol, atenolol, metoprolol, ismolol, and acebutolol. Then there are both alpha and beta blockers. We have a drug called labetalol, which has an ability to block both alpha and beta receptors. Then we have the third class of agents that are used to treat hypertension include calcium channel blockers, because if you see the action potential of cardiac muscle, it has a plateau phase. Plateau phase is due to the entry of calcium within the cell. So it means that the plateau phase in the cardiac muscle is here. If you see this is the plateau phase. Here, and this is due to entry of calcium within the cardiac myocytes or cardiac cells. So this is the phase of extended depolarization. This is the depolarization, and this is due to sodium here. This is due to sodium, but this is due to calcium. So if you block this, you can shorten this and you can decrease the contractility. So we have dihydropyridines, we have nicardipine, phalodipine, and amlodipine, nifedipine. Then we have others like verapamil and diltiazem. We studied in last lecture as well, which had antiarrhythmic drugs. Then this pathophysiology of hypertension also said that the peripheral vascular resistance, if the diameter of the vessel is less or vasoconstriction is there, then it will increase the peripheral vascular resistance. But if hypertension is there, we can use vasodilators. Then we have oral like hydralazine and minoxidil. Then we have parenteral like sodium nitroprusside, diazooxide, and phenoldiazepam. Sodium nitroprusside is also used in emergency condition in malignant hypertension. These are different sites where these drugs act. These are vasomotor center, centrally acting, and sympathetic ganglion like trimarathon. Then we have beta receptor on the heart. Then we have angiotensin receptor on the kidney, and many other. We will see it. Okay. We will see the individual drugs and their pharmacology. Centrally acting sympathoplegic drugs like methyl dopa. Whenever we study the drug, we study its mechanism, its chemistry, its pharmacokinetics, its organ system effects, and side effects as well. So methyl dopa is a prodrug and it is activated to active metabolite. So it means that it needs bioactivation through metabolism. While its main action comes from the activation of alpha 2 receptors in the centers. Here, this is activation of methyl dopa. Here you can see this alpha methyl dopa is administered. There is an enzyme aromatic L-amino acid decarboxylase, which converts this alpha methyl dopa into methyl dopamine, and methyl dopamine is further broken down or further metabolized into dopamine beta oxidase, so which is converted to alpha methyl norepinephrine. So ultimately this is alpha methyl norepinephrine. Just remember this. So this drug actually gives a false perception and acts as antihypertensive. So how and what is the mechanism of action? So what is the mechanism of action of alpha methyl dopa? It is, here you can see it is converted to alpha methyl norepinephrine. It is a prodrug. So what it does actually, here is the norepinephrine and normal physiology. Norepinephrine then is released out of the cell and goes to the receptors. This is a synapse. This is a presynaptic neuron. This is the receptor. Then this norepinephrine binds with these receptors and produces its effect. But what actually Aldomet, or this is a brand name for methyl dopa. Methyl dopa is converted to alpha methyl norepinephrine. So it actually fakes the presence of norepinephrine. It is structurally related to norepinephrine, and it binds to receptors. It binds to the receptors, and even if the norepinephrine is there, norepinephrine won't be able to bind with receptors. So this is how this can cause antihypertensive agent action. What are the pharmacological actions? Pharmacological actions are those actions which actually are induced by the drug on different organ level. It reduces peripheral vascular resistance, so it will lower the blood pressure, reduction in heart rate and cardiac output. Postural hypotension sometimes occur, particularly in the volume depleted person. Postural hypotension is hypotension is the lowering of blood pressure when you change your posture. For example, if you are lying down, then you just stand up and you feel dizzy. This is due to shift of blood volume to the lower part of the body. So this is called postural hypotension. So this drug can cause postural hypotension. It can cause the potential advantage of methyl dopa is that it causes a reduction in renal vascular resistance. So ultimately renal vascular resistance is decreased. It means that further renin and angiotensin system won't be activated. Plasma concentration of norepinephrine fall in association with the reduction in arterial pressure. Therapeutic uses are the uses in which the disease in which drug is actually used. Methyl dopa is useful in mild to moderate hypertension and preferred drug for the treatment. It is a drug of choice for the treatment of hypertension during pregnancy, based on its effectiveness and safety for both mother and fetus. The usual dose is 250 milligram twice a day. Then untoward effects, since it crosses blood-brain barrier, so sedation, particularly at onset of action, like the person feel sedated or sleepy. Long-term use can induce persistent mental lassitude and impaired mental concentration, and nightmares, mental depression, vertigo, extrapyramidal signs, but less frequently. So gonethidine is another drug that can act as antihypertensive. So how this drug acts, its mode of action. The drug prevents a normal physiologic release of norepinephrine from the sympathetic nerve ending. So here, this is, you can see vesicles containing norepinephrine. Here you can see these are the mitochondria. So these vesicles release norepinephrine into synapse. Here you can see this is one segment here. These are the vesicles. So these are the synapse. So what actually gonethidine does, it prevents the normal physiologic release of norepinephrine. So no norepinephrine will be released into sympathetic nerve ending. So it will block the hypertensive effect. So how it is transported? It is transported across the sympathetic nerve membrane by the same mechanism by which norepinephrine itself is being transported. And once inside the nerves, it is concentrated in the transmitter vesicles where it replaces norepinephrine. So how it actually replaces norepinephrine within the vessels. Which vessels? Here, these vessels. So these vessels will be replaced by gonethidine, and no norepinephrine would be there. So it causes a gradual depletion in the stores of norepinephrine in the nerve endings. So gonethidine pharmacological effect. The hypotensive effect or antihypertensive effect of the drug is associated with if you go back to the pathophysiology, it reduces the cardiac output, with bradycardia. Bradycardia is the lowering of heart rate. It decreases the heart rate, and relaxation of capacitance vessels. Capacitance vessels we saw in that diagram, where relaxation of capacitance vessels will increase amount of blood to be held in the vessels or venules. So later in therapy, it reduces cardiac output. Chronic therapy also decreases peripheral vascular resistance. Other pharmacological effect is venodilation. As capacitance vessels are dilated, so venodilation or the venular dilation occurs, so it reduces cardiac preload. How it reduces cardiac preload? Because if for example here, this is the heart pumps out the blood into arteries go into organs. These are the organs. Then organs give back or return the blood through veins. This is towards the organ, while this is towards the heart. So the amount of blood, if these vessels are dilated, the venodilation here, if these vessels are dilated, so these can accommodate more blood, and if it is stored, so lesser amount of blood will go back to the heart, because these vessels are giving the blood back to the heart, so it reduces cardiac preload. It means less amount of blood will be transported to the heart itself, and this will reduces the cardiac preload, or there will be a less pressure on the heart. Then inhibition of cardiac sympathetic nerves. It reduces cardiac output by inhibition of sympathetic nerves. Then renal blood flow and GFR are also decreased. Renin secretion is not reduced. Then obviously every drug has a side effect, so postural hypotension followed by exercise when the drug is given in higher doses, diarrhea, and pheochromocytoma. If some patient is suffering from pheochromocytoma, that is a tumor of adrenal medulla, it can produce hypertensive crisis, or this can cause. Then we have another drug, sympathoplasmic drug, that is rezapine. Rezapine stems its origin from a natural source and extracted from the root of Revolvia serpentina, a climbing shrub that is indigenous to our region. So mode of action of rezapine is it blocks the aminergic transmitters. Aminergic, like these are the transmitters that have dopamine and other norepinephrine. It take up and store biogenic amines. This is done probably by interfering with an uptake mechanism that depends on magnesium, and so this effect occurs throughout the body, resulting in dopamine, serotonin, norepinephrine, because it blocks their uptake into biogenic into the vesicles. So what is a normally what's going on here? Here you can see this is dopamine, here tyrosine, dopamine is then uptaken by dopa dehydroxycarbolase, Then dopamine is then uptaken into vesicles, and norepinephrine is being uptaken by the vesicles. Serotonin have vesicles. When the action potential reaches and when there is a need of these aminergic neurotransmitters or these neurotransmitters, these will be released. These vesicles fuse. These vesicles fuse with the cell membrane and exocytotically give off this neurotransmitter to the synapse. Then this synapse has a postsynaptic receptors, and these receptors actually produce the effects. So what actually this drug does, it blocks the uptake of these biogenic amines into vesicles. So there won't be any biogenic amines, so ultimately this cannot be released and produce effects. This is how these postsynaptic membrane and noradrenaline receptor, noradrenaline is being released here. Noradrenergic cell body, these are packaged into vesicles, and upon the entry of action potential, these are released and uptaken and bind with the receptors and produce effects. What this drug do is it blocks the uptake of these neurotransmitter into. So what are those biogenic amines? These biogenic amines are norepinephrine, dopamine, and serotonin. And these effects appear to be irreversible, and trace amounts of drug remain bound to vesicles for many days. Pharmacological effects or organ system effects, it reduces obviously by cardiac output and peripheral vascular resistance. Thereby it causes antihypertensive action, and since all the receptors are all the biogenic amines are blocked, so it causes postural hypotension. Heart rate and renin secretion is also reduced. Since renin secretion is reduced, so salt and water retention may occur. Therapeutic uses, this is rarely used, but in combination with the diuretic, it is used as an antihypertensive. It is a mild antihypertensive. At low doses, its side effects are postural hypotension and extrapyramidal side effects. These are pertaining to CNS. At high doses, sedation, lassitude, nightmares, severe mental depression. This is possibly due to blockade of serotonin. So if a patient is already depressive or a medical depression, then these are contraindicated. Then we have diuretics. Diuretics, we have seen a whole class of diuretic as independent drugs, but how diuretics act as antihypertensive agents. These diuretics and what are the mechanism of action of these diuretics to lower blood pressure? Drugs that alter sodium and water balance, these include diuretics. Diuretics lower blood pressure by depleting body's sodium stores. So it means most of the diuretics act by excreting out sodium. If you remember the concept of natriuresis, so initially diuretics reduce blood pressure by reducing blood volume and cardiac output. After 6 to 8 weeks of treatment, peripheral vascular resistance also declines because of sodium depletion. So obviously what actually happens, Diuretics, if this is the blood vessel, it has certain amount of blood in it. So diuretic actually cause excretion of sodium and water out of the body. So simply, this will lower the blood volume. If sodium is decreased in the body, then ultimately more effects will come out. So blood volume and cardiac output is reduced. Because of cardiac output is, again, when there is more blood is available, cardiac output will be greater. But after 6 to 8 weeks, sodium depletion will cause decline in peripheral vascular resistance. So use of diuretics, diuretics may lower blood pressure by 10 to 15 millimeter of mercury. So they, if the blood pressure is not too high, or it is on pre-hypertension or stage 1 hypertension, you can use them as a monotherapy. Monotherapy means they can be used as a single agent. No other drugs is given with them. So as monotherapy used to treat mild to moderate essential hypertension, and you remember that what is essential hypertension? It is without known reason. In severe hypertension, it is used in combination with vasodilators or sympathoplegic drugs, because these agents cause sodium retention. So these agents cause sodium retention. We have seen the side effects, and these drugs cause sodium excretion. Then we have potassium sparing diuretics to avoid potassium depletion and natriuretic effects of other diuretics. So next classes we will see in our next lecture. Thank you very much.